Let's get started with Chapter 1 of the BCSC Cornea and External Disease section. This chapter focuses on the structure and function of the external eye and cornea, laying the groundwork for understanding pathology later on. We'll cover the anatomy, physiology, and key features that keep the cornea transparent and healthy. These are the key highlights of this chapter. First, the external eye uses both anatomical and immunologic defense mechanisms to protect against infections and other ocular conditions. Second, a strong understanding of corneal anatomy is key for accurately classifying corneal diseases and for mastering keratoplasty techniques. Lastly, the cornea is a transparent avascular tissue. Its clarity depends on the organized arrangement of keratocytes, collagen fibers, and the extracellular matrix in the stroma, as well as the balance of forces that regulate stromal water content. The eyelids play a critical role in eye protection, distributing tears, regulating light exposure, cleaning the ocular surface, and maintaining the tear film. Eyelashes, or cilia, are the only hairs on the eyelid. They trap particles and serve as sensory triggers for reflex blinking. Blinking activates the lacrimal pump, helping to release and spread tears across the cornea, which clears debris. Average blink rates vary, 10 to 15 times per minute at rest, over 20 times per minute during conversation, around 5 times per minute during concentration, like reading. Finally, gaze direction also affects blink frequency. This section covers the muscle control of eyelid movement, skin structure, and glands near the eyelid margin. Eyelid motion is controlled by the orbicularis oculi, cranial nerve 7, which closes the eyelids, the levator palpebrae superioris, cranial nerve 3, which elevates the upper eyelid, the Mueller muscle, sympathetic, assisting upper eyelid elevation, and the inferior tarsal muscle, which retracts the lower eyelid. The eyelid skin transitions from keratinized to non-keratinized epithelium at the mucocutaneous junction, near the meibomian gland orifices. Glands near the eyelid margin include holocrine sebaceous and acrine sweat glands, apocrine glands, glands of Moll, and modified sebaceous glands, glands of Zeiss. Let's take a minute here to pause and review the anatomy of the upper eyelid. On the left, we have a detailed illustration highlighting key structures like the orbicularis oculi muscle, levator aponeurosis, Mueller muscle, and the meibomian glands, along with the arterial arcades and eyelid creases. On the right, we see an H&E stained histologic section that helps us appreciate the cellular architecture, including the tarsus, glands of Moll and Zeiss, and goblet cells within the conjunctiva. Use this moment to orient yourself to these layers before we move forward. The lacrimal functional unit, LFU, includes the lacrimal glands, ocular surface, eyelids, and their sensory and motor neural connections. Its primary responsibilities are regulating the tear film, including its lubrication, antimicrobial, and nutritional functions, maintaining ocular surface health, like corneal clarity and stem cell support, and supporting visual quality by preserving the image projected onto the retina. The LFU responds to environmental, hormonal, and cortical input. Afferent signals from the ocular surface and trigeminal nociceptors synapse with efferent autonomic and motor nerves in the brainstem. Autonomic nerves stimulate meibomian glands, goblet cells, and lacrimal glands, versus the motor nerves activate the orbicularis oculi to initiate blinking. The act of blinking serves multiple functions, including the expression of meibomian lipids, replenish the tear film from the inferior meniscus, spread tears across the cornea, and drain excess tears via the lacrimal puncta. Neural pathways of the lacrimal functional unit. The lacrimal functional unit is regulated by both sensory and motor nerves, primarily involving cranial nerve 5, trigeminal nerve, which supplies afferent sensory input from ocular structures, and cranial nerve 7, facial nerve, which supplies efferent motor output. Afferent sensory fibers, depicted in yellow, originate from the ocular surface, for example, the conjunctiva and cornea, and transmit signals to the trigeminal nucleus. Efferent parasympathetic fibers, depicted in green, originate in the superior salivatory nucleus. They travel via the facial nerve and pass through the geniculate and sphenopalatine ganglia to innervate the lacrimal glands, goblet cells, and meibomian glands. Efferent sympathetic fibers, depicted in red, modulate vascular tone and glandular secretion. Tear film composition and functions. The tear film is a mixed gel of mucus, fluid, and proteins secreted by the lacrimal gland, goblet cells, and the surface epithelium. This gel spreads over the glycocalyx of corneal epithelium, a carbohydrate-rich layer that coats the surface of cells in the cornea and conjunctiva, and is topped by a lipid layer that is secreted from meibomian glands. The tear film helps maintain a smooth optical surface between blinks, enhances refractive power at the air-tear interface, removes irritants, toxins, and debris, aids oxygen and nutrient diffusion to the cornea and conjunctiva, supports ocular flora homeostasis, and provides antimicrobial defense for the ocular surface. Take a moment to study this schematic of the tear film. You'll see it's composed of three main layers: a lipid layer on the surface from the meibomian glands, an aqueous mucin mixture from the lacrimal gland and goblet cells, and a mucin-rich glycocalyx anchored to the corneal epithelium. Each component contributes to lubrication, protection, and immune defense. Pause here and look closely at the different elements before we move forward. The conjunctiva is divided into three zones: palpebral or tarsal, which lines the inner eyelids and is tightly adherent to the tarsus; bulbar, which covers the globe, is loosely attached to Tenon's capsule and inserts into the limbus; and fornicele, which lines the superior and inferior fornices. Specialized structures include the plica semilunaris, which is a crescent fold at the medial canthus; caruncle, a fleshy ovoid structure in the medial canthus with goblet cells, lacrimal tissue, glands, and hairs; and lacus lacrimalis, which is the tear reservoir at the medial canthus. Conjunctiva, histology, and blood supply. The epithelium varies from stratified cuboidal in the tarsus to columnar in the fornices to squamous on the globe. Goblet cells account for up to 10% of the basal cells of the conjunctival epithelium. Substantia propria is a loose connective tissue that contains CALT, or conjunctival-associated lymphoid tissue. Regarding blood supply, the palpebral conjunctiva shares supply with the eyelids, versus the bulbar conjunctiva is supplied by anterior ciliary arteries which branch from muscular branches of the ophthalmic artery. Conjunctival capillaries are fenestrated and can cause chemosis in inflammatory and allergic states. The sclera is a dense, opaque, white fibrous tissue that extends from the corneal limbus to the optic nerve, where it merges with the dural sheath. It is composed of three layers, from outer to inner: the episclera, stroma, and lamina fusca. The scleral stroma consists of collagen fibers with variable alignment, which contrasts with the uniform arrangement in the cornea and accounts for the sclera's opaque appearance. Its vascular supply comes from the anterior and posterior ciliary arteries, and it drains via the vortex veins. The thickness of the sclera ranges from approximately 0.3 millimeters, just behind the rectus muscle insertions, to 1.0 millimeters elsewhere. Innervation is provided by the ciliary nerves of cranial nerve V1, the ophthalmic division of the trigeminal nerve. The cornea is a transparent avascular tissue composed of 5 distinct layers: the epithelium, Bowman layer, stroma, Descemet's membrane, and endothelium. Its horizontal diameter measures approximately 11 to 12 millimeters, and vertical diameter about 10 to 11 millimeters. The central corneal thickness ranges from 500 to 600 microns, gradually increasing toward the periphery. The cornea receives glucose from the aqueous humor and oxygen from both the tear film and limbal circulation. It is highly innervated by the long ciliary nerves, branches of cranial nerve V1. Notably, the cornea has the highest density of nerve endings in the human body, contributing to its exceptional sensitivity. The cornea is divided into distinct zones based on curvature and anatomical function. The central zone, 1 to 3 millimeters, has the steepest curvature and resembles a spherical surface. Surrounding this is the paracentral zone, 3 to 4 millimeters, which gradually flattens as it extends outward. Together, these form the apical zone, which plays a critical role in refractive power and is essential in contact lens fitting. Beyond the apical area lies the peripheral or transitional zone, spanning approximately 11 millimeters in diameter. This zone exhibits the greatest flattening and asphericity. Finally, the limbal zone, around 12 millimeters, is where the cornea begins to steepen again as it approaches and blends with the sclera. The corneal epithelium is 40 to 50 microns thick and is composed of 4 to 6 layers. It contains tight junctions between cells that acts as a barrier for tear fluid entering into the stroma. Continuous proliferation from limbal stem cells gives rise to other cell layers, which differentiate from deeper cells into superficial cells. As the maturation process occurs, mature cells become coated with microvilli on their outermost surface, which forms the glycocalyx, and finally desquamate into tears. This process of cellular turnover occurs in 7 to 14 days. The Bowman layer lies between the corneal epithelium and the stroma. It is an acellular layer composed of irregular collagen fibrils approximately 15 microns thick. This layer helps maintain the overall shape of the cornea. Importantly, if disrupted, the Bowman layer does not regenerate, which has implications for both trauma and surgical procedures involving the anterior cornea. The corneal stroma constitutes approximately 90% of the cornea's total thickness. It is composed of keratocytes, or flattened fibroblasts, collagen fibers, and proteoglycans. Structurally, the anterior 40% of the stroma is denser and possesses twice the tensile strength of the posterior 60%. Over time, keratocyte density naturally declines with aging and can be further reduced following laser refractive surgery. Corneal transparency depends on the organized arrangement of keratocytes, collagen fibers, and extracellular matrix, which minimizes light scatter. Transparency also requires precise regulation of stromal hydration, maintained at about 78%. This hydration is controlled by the epithelial and endothelial barriers and sodium-potassium pumps in the endothelium, which regulate fluid movement. Swelling pressure is generated by negatively charged glycosaminoglycans in the stroma that repel each other and draw in water. To preserve clarity, this inward force is balanced by intraocular pressure. The resulting imbibition pressure, which helps maintain fluid equilibrium, is defined as imbibition pressure equals intraocular pressure minus swelling pressure. Swelling pressure is a baseline inward force, and IOP is a counterforce, with the endothelium as the true regulator of corneal edema. The basement membrane of the corneal endothelium thickens with age. At birth, it measures approximately 3 microns, and by adulthood, it reaches a thickness of 10 to 12 microns. An important anatomical feature associated with this region is Schwalbe's line, which serves as a gonioscopic landmark. It marks the transition between the endothelium and the trabecular meshwork, helping to delineate anterior chamber angle structures during clinical examination. The corneal endothelium is a single layer of hexagonal cells lining the posterior cornea, forming a mosaic pattern. As mentioned in a previous slide, it plays a critical role in maintaining corneal clarity by actively pumping excess fluid out of the stroma into the aqueous humor via sodium-potassium pumps. This layer has limited regenerative capacity. When cells are lost, the remaining cells enlarge and migrate to maintain coverage. While the central endothelium is generally non-mitotic, there is experimental evidence suggesting some mitotic activity in peripheral cells. Rho kinase inhibitors have been shown to potentially augment migration of endothelial cells. Endothelial cell density decreases with age from about 3,400 cells per millimeter squared at age 15 to 2,300 by age 85. A normal central count ranges between 2,000 and 3,000 cells per millimeter squared, and a density below 500 is associated with a high risk of corneal edema. The limbus is the transition zone between the cornea and sclera, serving as the reservoir for corneal epithelial stem cells. These stem cells are essential for epithelial renewal and wound repair, with regeneration occurring in a centripetal pattern from the periphery toward the center of the cornea. Damage to the limbus disrupts this regenerative capacity and compromises the barrier function, potentially allowing conjunctival invasion and neovascularization of the ocular surface. The palisades of Vogt, seen as radial fibrovascular ridges in the superior and inferior limbus, mark the location of the stem cell niche. That brings us to the end of this section. Thanks for your attention. Take a moment to review any areas that felt unclear, and when you're ready, move on to the next topic. Please review the questions we have provided at the end of the video.